Hi, I'm Miranda Marshall, and today we will be discussing whiplash-associated disorders. Whiplash is a form of neck injury caused by a forceful impact that leads to an aggressive back and forth or a side-to-side movement of the neck. Whiplash most often occurs in motor vehicle accidents that happen from the rear end of the car, which will cause hyperflexion and hyperextension. Side impacts will cause a lateral flexion of the neck as well as the torso towards the side of the impact and then away. Front end impacts are a lot like rear end impacts in the fact that they're just opposite. It will be hyperextension and then hyperflexion. Whiplash can result from many other things other than motor vehicle accidents. It can happen from physical abuse, sports accidents, or any other aggressive trauma such as a fall down the stairs, anything that causes the whip-like motion of the C-spine. So when looking at the spine in a cadaver study, it was discovered that whiplash will occur in 3 different stages, starting with a rapid loss of lordosis in stage 1 at the upper and lower spine because they will start to experience flexion. Stage 2 consists of the spine taking on an S curvature in order to make the neck lordotic again. It's basically the body's way of finding its center of balance again. And the third and final stage, the entire spine will go into extension, which will cause an intense compression on the facet joints. So with this in mind, not only is the spine affected, but the muscles are affected as well too. Some of the main muscles that are affected in a high impact would be the sternocleidomastoid, the semispinalis, your splenius capitis, as well as your upper traps. The higher the impact, the higher the strain on the muscles will be, so the more likely that deeper muscles will be affected as well too, so like your deep cervical neck flexors. So with this in mind with the spine and the muscles, you want to make sure to treat the muscles to loosen any sort of intense muscle guarding so the facets aren't being compressed overly and no further injury will continue. So the rate of recovery will vary from individual to individual depending on their past history of prior injuries. If they were lacking any stability prior to the event, they will probably take a little bit longer to recovery. The road to recovery will be a little bit longer, the severity of their WOD will also be a determining factor of how long it will take for them to heal, as well as their age and how accessible treatment is. A lot of people will just ignore their whiplash and they won't get it treated, and that can lead it into chronic stages, which can then lead to lifelong physical impairments and pain. So with this in mind, we're going to move on to signs and symptoms. So typically in the acute stages of a whiplash, the complaint is posterior neck pain with radiation into the occiput, the shoulders, or the upper back. Some clients may also experience headaches. This isn't the referral or radiation up into the occiput. They actually just experience headaches from the trauma, as well as limited range of motion within the neck from muscle guarding, as well as possible neurological issues. In chronic stages of whiplash, spondylosis can start to happen, which is one of the most common causes of radiculopathy in whiplash patients. Patients in this stage can possibly experience numbness, tingling, as well as muscle weakness due to an entrapped nerve root. In order to avoid this, it's really important to reduce muscle tension within the neck. You can use massage or dry needling. Both have been proven to have been really effective. And you want to make sure to treat all tender and shortened muscles in this case. Okay, so when assessing someone or treating someone with a whiplash-associated disorder, it's really important to make sure that you include every segment of the body. It was actually proven in a case report done on whiplash-associated disorders. There was 43 patients. 76% of them experienced just neck pain, but 74% of them reported shoulder and arm pain. 64% of them also experienced low back pain, 54% experienced dorsal back pain, as well as another 54% experiencing pain radiating into their leg. There was 40% of them that experienced headaches, and 44% of them experienced TMJ issues, as well as facial pain. This shows that whiplash-associated disorders can affect the entire spine and not just the C-spine. So any examination or treatment on WODs should therefore include every part of the body. During your first examination with a client, you want to make sure to assess their movement the second you see them. When the patient is unaware, you're looking for their gait and posture or any sort of muscle guarding. If they come to you as a first-line provider of care for them, it's really important to assess their stability of their neck before you move on to any ranges of motion, just because you don't want to cause any further damage. So it's recommended that you perform the vertebral artery test, as C4 to C6 can typically be very hypermobile, and you don't want any compression of the vertebral artery happening. You then can do the lateral flexion alar ligament stress test, rotational alar ligament stress test, transverse ligament stress test, or the cervical flexion rotation test. This will all test for ligamentous stability. The cervical flexion rotation test will also test if there's hypermobility at C1, C2, and that could also be a DENS issue as well too. You can then do the sharp purser test. This needs to be done with extreme caution. You definitely want to do this if they are coming to you as their first provider of care, because you want to make sure there's no subluxation of the atlas or axis happening. So after ligamentous stability has been assessed and there's no red flags, you can then move on to the client's range of motion. So during active, you want to make sure their shoulders are upright and they're in an upright position and there's no compensating movements happening, so you can get an accurate reading of cervical limitations. And you also want to know any pain or the degree of mobility that the person has and the ease of their motions. Passive range of motion, you want to be looking for spasms, because spasms can indicate an unstable joint. This is best done with the patient supine, lying down in a nice relaxed position. You want to palpate for tenderness and spasms. You want to include the spinous process, the interspinous ligaments, and the prevertebral areas up to the occiput. You want to note any tenderness or trigger point areas. The trapezius and the sternocleidomastoid will more than likely have lesions or trigger points in them, as they suffer the most strain in this type of injury. If a client reports any numbness or tingling, it is really important to do neurological testing to see where the problem is coming from. In acute stages, it's likely to be a disc herniation or a top muscle compressing a nerve. In the chronic stages, though, it is possible that bone is forming in between the vertebrae and spondylosis is occurring, making it important to assess any sensory loss of DTRs, or finding where the nerve root compression is coming from. So when doing this, you want to make sure the spine is always in a neutral position while you're palpating, just so you can get an accurate read. If there's anything that is asymmetrical or of concern, you definitely want to make sure to refer out. So let's discuss treatment. Back in the day, they actually used to use foam collars to immobilize the neck in order to keep it safe. But studies have actually shown that immobilization can lead to muscle atrophy and muscle weakness. So they actually don't recommend this, because you need that muscle guarding there in order to maintain stability of the neck. If you are going to use the foam collar, it is recommended that you use it for no longer than 72 hours after the impact, or only 3 hours a day, or if needed at nighttime. And you want to do this with the direction of your doctor or healthcare provider, because immobilization has actually shown the least improvement on the road to recovery. Ultrasound and massage can be used to relieve muscle pain for whiplash-associated disorders, and have had shown quite an efficiency in reducing pain and muscle tension. First-line treatments, though, that typically are most effective consist of analgesics, non-steroidal anti-inflammatories, ice, heat, and early exercise interventions. So, with this in mind, it's important to remember to treat all areas of the body where any asymmetry has taken place. As we discussed before, all parts of the body can be involved. This is because in a side impact, the torso can be involved as well too. So if you've had something along those lines, the QL can be affected, or the hip can be affected, anything like that. And eventually your body's going to try to make up a center of gravity, so all these structures will start to become uneven. So you want to make sure to address all structures around the injury. So in the acute stage of treatment, you want to decrease pain with superficial reflex techniques using the gait control theory to reduce pain. You then want to work any compensating structures or any other structures involved, so like we discussed before, like the QL and a side collision. You want to increase local circulation in order to promote healing, but you also want to decrease edema to reduce inflammation and pain. Making sure that all this work is light because they're still in acute stages, and you don't want to remove all the muscle guarding as it's there for stability. So then moving on to the subacute treatment stage, you still will probably want to decrease inflammation and edema at this point, because they will likely still have some. Decrease pain again with superficial reflex techniques, as well as you can then begin to work on some trigger points that might be found in the traps and splenius capitis, sternocleidomastoid. You then want to prevent any adhesions from further happening. And you also want to decrease any spasms that are happening, but you don't want to decrease any protective muscle spasms, as they are there once again for stability. Another good thing in this stage is to maintain the range of motion that they do have. So any sort of passive movements or stretches would be good. In the chronic stages, you want to decrease the sympathetic nervous system firing in order to relax them a little bit more and have their pain levels be decreased. You also still want to be working on compensating and other structures involved. This point, you do want to decrease some of the muscle guarding and the hypertonicity of the muscles, as well as the trigger points. You can start to increase range of motion at this point, remembering that it is still there for stability, but we can go a little bit further this time. And we also want to increase local circulation. You don't want to ever stretch or hypermobile or mobilize joints C4 to C6, because these ones are typically hypermobile and we don't want to cause any damage. So with this in mind, some of the remex that we could do and send patients home with, now that we know that exercise will lead them to a quicker road to recovery, rotating the neck in both directions and getting a good stretch. You want it to be pain-free and bilaterally. You also can tilt head side to side and bending your neck towards your chest, and then rolling shoulders as well too. Just kind of keep things loose in there. We just want to loosen things up, but in a light manner. So we don't want to overstretch it or anything like that. A lot of times too, it's recommended, especially by the Mayo Clinic, they recommend putting a moist heat to the achy area prior to exercise, or even taking a warm shower, in order to help the muscles do what they need to do and not cause any further strain. Thank you.